Good morning. I see that we're right at 10:45, so I think that we're going to go ahead and get started again. I'm Shelley Resinkovich, and I'm part of Michael Pensine's office. I'm glad to help him with some of the flow of this next segment. So we're very pleased to introduce next Dr. Marta Wosińska, who's going to be talking about a better alternative to lockdowns. Dr. Wosińska is a Deputy Director for Policy in the Margolis Center and a consulting professor in the Fuqua School of Business.
Thank you so much, Shelley. Can you see my screen? Because for some reason I can't see it, but I'm supposed to be screen sharing. Can you see it?
Yes, we can.
Excellent. Well, thank you so much for having me here. It's a great opportunity. I am actually relatively new to Duke. I came on board at the very end of October to join the Duke-Margolis Center. I'm the Deputy Director for Policy. The director of the center is Mark McClellan. 4 months into the job, COVID hit, so it's been quite a transition into a new position. And so I welcome the opportunity to present here. We have been doing a tremendous amount of work on COVID in healthcare delivery, in containment, in biomedical innovation. This work is something that came out through my exposure, through my collaboration with a couple of other organizations, Resolve to Save Lives and United States of Care. We have jointly come together to put forward a dashboard that some of you might have seen called COVID Exit Strategy. Through that, I've been exposed to this really neat framework that I think you will find helpful. So this is actually a figure that I saw in the Washington Post yesterday that shows you how dramatically different the US experience has been. These data are actually scaled to the population. This is the number of cases per 100,000 people. And this is even probably an underestimate because we have not been testing as much as some other countries. You can see that the South Korea experience is just dramatically different. But also, even though Europe has had this incredible surge, sort of similar to what has happened in the US, their lockdown played out somewhat differently. They've had a rapid decrease in cases. And they have also reopened, and that their experience with reopening has also been different. And so what I wanted to do is to provide a perspective to why that might be the case. So this is sort of a neat way to explain it. And you have heard all of these terms, but I just like how it pulls it together. So the concept is sort of you want to box in the virus. And, you know, we have all heard about this it's all about testing and testing and testing. Well, actually, testing is sort of the first piece of it. You need to test. And why do you test? It's so that you can tell who needs to isolate. And so that you can also find out who else they might have been exposed to and might have infected. So this is where the tracing comes in. And then in turn, so that you can tell those folks, those contacts, that they have been exposed, and have them quarantine themselves and potentially get tested. And this is sort of a way that you box in the epidemic. A stay-at-home order is a very crude way of boxing in. It's basically you try to cut the transmission, have very few people interacting with each other, but this is sort of a way to think about this as an alternative. And the one piece that I think is missing from this box it in framework are the masks. So I've added here a few masks as an addition. So the box it in actually has been very challenging for some communities. And this is actually one reason why the lockdowns have not played out the same way in the United States as they have in, let's say, Europe. And the way you might want to think about it is that certain communities have a much higher probability of getting infected, and then they have a much higher probability of having an adverse outcome if they're infected. So there's a really large economic component to this. sheltering in place actually does require resources. And this might be really challenging for anybody with a low income. I remember back in very early March, I went to a Home Depot, and I remember seeing somebody who was like ready to basically go on a work site, picking up certain things, and he was coughing. And I was really far away from that person, but it made me sort of realize he really doesn't have much of an option. If he doesn't work that day, he doesn't get a paycheck. And so he's making very much an economic calculation. Also, another reason why there's higher probability of getting infected is, household and neighborhood densities are different in lower income and with the vulnerable populations. Then in terms of sort of the probability of having an outcome, there are underlying comorbidities that can very much exacerbate the problem, among them heart disease and diabetes. And then of course, there's also the component of insurance and the access to quality care that prevents people from actually getting care that might help them to deal with the virus. So as a result, this is, not a surprising, this is a familiar picture to all of us, is that there are dramatic racial and ethnic discrepancies in outcomes. And we have also seen that also in testing. So again, this goes back to both the piece about why we have had a harder time containing this epidemic during the lockdowns, but it also explains why we have been challenged to actually contain the epidemic and suppress it as we have reopened. So I wanted to perhaps close with, a number of speakers earlier said, you can't improve what you can't measure. So I wanted to kind of tell you how we're doing and being able to get an insight into how we're doing here. So the data on testing is improving. There are still a lot of gaps. It is hopeful that the HHS guidance that was previously discussed is going to help, but we have a long way to go on that. We have really no data to what extent people are isolating themselves. The data on contact tracing is also really, nobody is really reporting it. We might know that some states are trying to hire. Something that's really critical is that it's not just how many contact tracers you hire, so the people who are going to ask, who are you exposed to and call up. There's also a need for care coordinators. Again, the key here is to identify who might be infected and then take them out of circulation and allow them to sort of function within home or some other safe place so they don't infect others. And care coordinators can help connect people with services such as food, medication, and whatnot, and potentially even having a different place to stay so that you don't infect your family. So very little data in this space, so it's hard for us to know exactly how we're doing. We have just general sense of what needs to be done, but this is an ongoing struggle. So I'll stop with that and take any questions.
Wonderful. Thank you so much for a very interesting overview. So it looks like from the audience that there's a lot of interest in contact tracing. And well, I see that Michael Pancina is coming up. Michael, were you interested in delving into that more or another subject?
Let's start right the contact tracing question with the audience. But I think, so where do we go from here? I think it's the question that's kind of pressing on my mind, right? The first figure you showed, I really don't like the incline in the US, right? And I think you've articulated what the reasons for it might be. But if you were in charge, right, of running the CDC, what 2 or 3 steps would you take?
Yeah, so I will say, I've been having conversations with a number of behavioral scientists here at Duke. Peter Obel at Fuqua has gotten together a number of behavioral scientists to think about ways to get people to play along with this relatively straightforward way to engage. How do you get people to wear masks? How do you get people to social distance? Government mandates actually can get a lot of pushback. They might not actually be the way to go. So, you know, an alternative is to actually, and this has been actually mentioned in some earlier presentations, getting involved in the community, trying to understand what the community needs. What is it that's preventing them from either, you know, getting tested, from isolating, from providing information and being willing to actually share information. So this is about sort of identifying who do they trust and who could be a spokesperson for them, and then basically trying to connect within the community. But that's really at the level that this needs to be done at.
Yeah, no, that really brings back what Dr. Law said in the beginning, and I think makes what Laquana Palmer presented, right, in terms of ability to collect data on the North Carolina level, so important.
We have a question that seems like it might be of interest, especially how will we handle if there was contact on the third degree, for example, such as a coworker who was in contact with someone who had been in contact, a coworker who was in contact with someone having a pending COVID testing.
So I think, you know, there's different guidance in different places, but you can only go so far. So I will tell you, for example, what the experience in Germany, which is interesting. When they were doing contact tracing, and they're very involved in contact tracing, they will look at sort of look at people who have had a tremendous amount of exposure, like, for example, living with somebody. And even sort of the CDC guidance is, I believe, having been within 6 feet of each other for at least 15 minutes. That's considered a contact. That, of course, only goes so far because we know that a lot of the spread was, you can do it in public transportation and whatnot. It might be really challenging to do. What has happened in Germany is that they actually just tell people to self-quarantine, which I think because of social services, it's a much more feasible way to go rather than go get tested. I mean, part of the problem is that if you tell somebody to go get tested, if they get tested too early, they might not actually come out to be positive, and that might actually break the chain. So it's a bit tricky about sort of at what point is the right place to get people tested and how you kind of balance that out.
Thank you very much for sharing your expertise with us. And I see that we have perhaps one or two more open questions. I'm afraid we will need to move on, but we encourage the audience to continue asking and sharing your thoughts with us.